behalf of Medicine 4. 29-year-old male from Vallimalai was admitted with complaints of fever for past 1 week, which was a high-grade fever with chills and rigors. He also had a right ear pain with ear discharge for the past 5 days, which was whitish, and it was foul smelling initially, but for last 2 days, it is not foul smelling. It was not bloodstained. Later, 2 days later, he also developed right side neck fullness with pain for 5 days. This was not associated with difficulty in swallowing. Further, 2 days later, he developed a right-sided frontal headache, which was associated with mild non-projectile vomiting, but there was no diplopia, no features of seizures, or no history of weakness of limbs. For these complaints, he was initially taken to an outside hospital, treated with antibiotics, but he had come here in view of the decreased appetite and urine output he had come here. Past medical history. He had history of epigastric pain with radiation to the back in 2019. It was only told to him as pancreatitis and was conservatively managed. He has had 3 similar admissions in the past for similar complaints. Since 2019, he also noticed an unintentional weight loss of 15 kilograms. In one of the admissions, which was previously mentioned, he was found to have raised sugars of about 400 milligrams per deciliter, but he has not been treated for the same. Personal history is a chronic alcoholic since 2013 at the age of 19. He used to drink about 360 ml of ethanol per day. Last binge was about 10 days back. And he's also a chronic cigarette consumer for past 7 days, uses 1 cigarette per day, and history of substance abuse. On examination, vitally he was stable. The right ear, there was no ear deformities, but there was mild tragal tenderness. And external auditory canal, there was copious discharge present, but there was no granulation tissue, or it was not blood tinged. And right cervical region masted as well as parotid region, there was a fullness present with warmth, tenderness, and induration, but there was no lymph nodes palpable. Systemic examination was normal. So based on this clinical syndrome of fever with ear pain and ear discharge, neck fullness, and a frontal headache with decreased urine output, and systemic examination predominant of auditory findings. At the outset, we were thinking it could be a primary autogenic infection, probably a right malignant otitis externa, or a complicated acute otitis media with complications. That is a cervical region, it could be an abscess from necrotic nodes, or if it is an IJV thrombosis like a Lemierre syndrome, or if it is intracranial complications in view of the frontal headache. The other problems that he had was a uncontrolled probable diabetes mellitus, pancreatic more than type 1 with a nicotinic and chronic alcohol dependent syndrome. His baseline investigations showed mild leukocytosis, considering the fact that he has received a course of antibiotics outside, but neutrophils were 88%. And the peripheral smear showed neutrophilic leukocytosis with grade 3 toxic changes. His platelet count at presentation was 1,37,000. Serum electrolytes were normal, liver functions were normal. And his RFP, which mainly showed elevated renal parameters. And urine microscopy was done, which showed pyuria as well as hematuria. Phase contrast showed a dysmorphic RBCs, suggesting of a glomerular hematuria. So here, and we did an ultrasound abdomen also to rule out any other causes. It showed a grade 2 renal parenchymal changes. So we assume that it is a glomerular nephritis. At this history, it is like an infection-related glomerular nephritis on a chronic kidney disease, probably diabetic. An ultrasound of the neck also was done, which showed subacute right IJV thrombosis with adjacent inflammatory changes with necrotic lymph nodes in level 5A. Thyroid, parotid, and submandibular glands appeared normal. So to rule out any skull base extent, we took a blood culture as well as the right oral pus culture, which grew Klebsiella pneumonia. The right oral pus culture also grew Klebsiella species. The string test as well as the PCR for RMPA1 and 2 and Arobactin results are awaited. And MRI and CT temporal bone was also done, and it was consistent with the skull base osteomyelitis, with extensive opacification hyperintensities in the right external auditory canal, middle ear, mastoid cells with altered signal intensity, and swelling extending into the adjacent skull base. And there were minor erosions in the tegment tympani with thrombosis of right transverse, sigmoid, and IJV. There is no other definitive extradural or subdural collections. And the other problem, which was his raised sugars, HbA1c was 10.7. His fasting C peptide is awaited, And here, if you could see, we could note the calcifications which is present. So most likely his uncontrolled diabetes was related to chronic calcific pancreatitis. So coming to the diagnosis, we diagnose acute right-sided autogenic infection with lateral skull-base osteomyelitis with septic thrombosis of the right IJV with intracranial extension to transverse as well as a sigmoid sinus. Blood and pus culture has grown Klebsiella pneumonia. The hypervirulency part is awaited. Uncontrolled diabetic with an acute and chronic kidney disease. So I would like to discuss about the Lemierre syndrome. So Lemierre syndrome, it refers to the septic thrombophlebitis of the internal jugular vein. So primary infection, most of the times it's going to be pharyngitis or tonsillitis affecting the tonsils, but less common primary sources can be odontogenic infection, mastoiditis, otitis media. So primary infection followed by inflammation of the vein, formation of a septic thrombus, and then which seeds like persistent bacteremia with septic emboli, that is the pathogenesis of the septic thrombophlebitis. Most common complication of Lemierre syndrome will be a septic emboli to the pulmonary vessels, which causes a necrotizing lesion in the lung, or it can also cause a large joint septic arthritis. The interval between the infection onset mostly is 1 to 3 weeks as per studies. So the main principles of treatment here are appropriate antibiotic therapy with source control. And the question here lies whether we have to anticoagulate this patient or not. This was a case report on usage of anticoagulants in patients with Lemierre syndrome. A series of cases were seen. Based on the results, there was clinical improvement following combined treatment with antibiotics and anticoagulation therapy. However, there are no clear guidelines for the same. But because of the rarity and lack of randomized control trials, but expert panel had suggested anticoagulation in the setting of extension and extensive thrombosis, and there is continued fever or bacteremia, even 5 to 7 days of appropriate antibiotic therapy. In our patient who presented first with fever and then he had a ear discharge, and then when he developed the headache, which was clinical progression history was there, we had anticoagulated him. And regarding the duration of the anticoagulants here, provided they don't have a history of prothrombotic state, it is suggested to stop once the patient has improved clinically and the thrombus extension has ceased. We had repeated the scan in our patient. There is no further extension of the thrombosis. He also clinically, he is afebrile for the past 7 days. There's no fever. He clinically improved. So thereby we had stopped the anticoagulation also. And this APLA workup, basic workup is negative. The learning points is Lemierre syndrome and management of the same. Thank you.
Thank you, Dr. Shrithi. What happened to the renal function?
Renal function now, the last, sir, it is gradually increasing only, but we are mainly monitoring the input as well as the output and matching the daily balance. There is no uremic or metabolic complications at present for dialysis. His creat had gone up to 10, with urea of 110, but he is clinically stable. Nephro is seeing him daily, not dialyzed him.
And why do you think he had weight loss of so many kilos over 2-3 years?
Over there, I think it could be related to diabetes because of.
Yeah, I think because I come from a gastro-liver background, also that he had pancreatitis, chronic pancreatitis.
That can also.
There might be exocrine deficiency also. The albumin is also low. If it is only AKI, then albumin, if it's not a renal loss, maybe he's got a malabsorption or a maldigestion because of pancreatic problem. So anticoagulation, how long are you planning to give?
So we had stopped it because there was no, clinically he improved, there was no fever, and also the repeat imaging doesn't show any extension of thrombosis. Studies say that if there is history of thrombophilia or any prothrombotic state, we have to anticoagulate based on it. But here it was infection related, so we had stopped.
You gave it for a week or less?
Week.
Questions?
Considered organizations
but it was provoked by an infection. So as per studies, it is suggested to stop.
Sakshi's point is even provoked deep vein thrombosis, give for 6 months and then discontinue. So here we have stopped within less than a week. So that is the concern in the house generally. Are we cutting it too short? If it extends, the implications here is very high because it's straight going to involve CVT.
can I take the question, Santosh? I'm online. We were just reviewing the literature for sepsis-related thrombosis. Actually, there are pros and cons to anticoagulation. So there are some studies which show that upon anticoagulation, there is a high risk of septic emboli. So that's the flip side. The reason being that when it is not purely a prothrombotic state, but rather a sepsis-related thrombus, the thrombus itself is very, very friable. So when anticoagulation is started, the risk of septic embolism goes really high. So that is the reason most of the studies do not conclusively favor anticoagulation itself. So even in this patient, there are very specific indications to initiate anticoagulation, like a progression of thrombus. So historically, when we saw there was a facial swelling followed by headache, so we thought the IJV thrombosed and then it progressed into the sigmoid sinus. That is the reason we even proceeded for anticoagulation. If not, if it's a stable thrombus under close clinical monitoring, the recommendation actually says that we do not anticoagulate. So he had a specific indication for short-term anticoagulation, which is actually very, very short-term, and we did stop it because once the progression of thrombus is fairly halted and the infection is taken care of, which is the precipitating factor, we could stop the anticoagulation. So this sepsis-related thrombosis is actually, it's not very well studied, but there are major disadvantages to anticoagulation also in this case. Just that it was through our reading that we found out these things. Thank you.
Thank you, Esther. So just two closing comments. Basically, we see a lot of patients with alcohol use. So try not to use the term chronic alcoholic. It's better to say harmful alcohol user or consuming a large amount of alcohol than label somebody as alcoholic. Other thing is this patient may need pancreatic enzyme supplements after looking for exocrine deficiency. Okay, thank you. Should I give away this to the best presenter? I mean, all cases are interesting. A lot of neuro cases. I'm not sure if this is the general trend. Can I call Dr. Brightland Man versus B?